started. Before I get into my own thoughts, I figured I'm going to do this for the introverts in the room. And I'm going to ask you just to raise your hands if you have an answer to one of these questions. Did anyone in this room learn something new today? Okay. Did it confirm something you already knew? Okay. Did this panel workshop raise more questions than answers for you? Okay, it's good. And did you feel something was missing? Wow, impressive, except for food, and I'll get back to that in a minute. So can we just, before I start talking, can you just take 2 minutes and jot down some of those answers to those questions? What did I learn that was new? What was reconfirmed throughout the day? What question was raised for me today? And for those of nothing was missing, then nothing was missing. So just jot those down because we do want to elicit your thoughts. Third question was, give me a second, I'm on the page. More questions than answers. So what questions were raised for you today? If your brain is hurting, just jot down a few words. All right, so hopefully you jotted enough that you can share with us. It doesn't have to be a whole thesis on it. But let me come back to this analogy of food, right? So the first half of the day, we're all a little bit hungry. I think that first speaker, boy, she kept hitting on the fact that there wasn't any breakfast this morning. And while people were talking today, I was thinking about one of my favorite foods, one that Jim Nickman loves to make after Thanksgiving. That's a turkey chili, right? We all make some variation of a turkey chili. But I think everyone in the room would agree who's ever made one or tried one that there's some basic ingredients, right? You need some turkey meat, you need some beans, right? You need a pot, you need some fire, and you need some chili pepper. Those are basic ingredients of what you're gonna make is a chili pepper. You can add everything else in your kitchen cabinets to your taste, but to make a turkey chili, you need some basic ingredients. So I wanted to take that analogy and give you what I thought I took away in terms of common themes today. So for me, the turkey was joint collaboration. You need joint responsibility. You can't go at this alone. If you're trying to bring scale, take something to scale, and you think you're at it alone, you're going to fail. You need people to take ownership and responsibility for the issue and the solutions, right? And when we did the exercise this morning, I think what was really telling was that we were in certain circles where we didn't know one another. But whether it was our shoes or our hairstyles or the clothes we were wearing, there was a certain affinity, right? And to bring that joint collaboration, we have to find that common language and affinity. And I think, Jeanette, you said that, right? You said we have to find those common themes. And George, you raised a question this morning about values, ideas, and beliefs. And I think one thing that's resonated with me is that in order to bring that joint collaboration and that joint responsibility is that we have to find those common beliefs and value systems and build from them, right? Not imposing what we're trying to change, but build from them, which takes me to the next important ingredient, which is the beans, right? You need community engagement. The biggest public health failure is that we love to design things and then impose them on people. We love to create programs and strategies and then take them to scale. We love to take, and it's good to translate research into practice, but how often does that research really take in what the community wants and what they say they need, right? So how do we make that happen, that community engagement? And I gotta say that requires listening, not imposing. Joe, you talked about just this important value of if we attempt to build something and impose it, people will always reject it. You have to build from where people are at and what they're saying is important to them and engaging from that end. And I have to say that the analogy this morning on Facebook was a good one, right? Facebook worked because it builds on what there's an inherent desire and need to connect. And Facebook just provided a mechanism to connect. And that's why it grew so quickly. When we engage, we learn what makes people tick, those desires that are common to one another. We don't have to impose ideas and values. When we learn what the community wants and we engage them from the front end, we can build things based on beliefs and values that the community want and make something grow to scale, right? Facebook, Apple, George, you said this, businesses have figured out how to do this. They know how to build a market. They know how to build a demand for something we don't even know we want, because they're basing on some inherent desire or need. A 2-year-old will walk up to a screen and start pushing it with their fingers now because they're learning that if you touch a screen, something happens, right? None of us knew or could appreciate wanting to get information easily from a phone and move things around with our fingers, but Apple created a need and responded to a need to get information quickly, and they figured out how to do that, right? We as public health people always start with what we think the need is, as opposed to hearing from the people. The third ingredient, this is my chili powder, is the data. And not the traditional data of research, of looking back to see what worked, but data that's useful and relevant, as Jeanette said, data that's local, data that helps us plan, to strategize, to think about what the aim is. Paul Jelinek, who's here, wrote an excellent commentary together with Stephen Isaacs in the Chronicles of Philanthropy on the denominator when it comes to scale. How often are we thinking about a denominator? Family nurse partnerships, the National Diabetes Prevention Program are failures. They're public health failures when you think about the amount of people that actually can benefit from these programs, because we're trying to take the nuts and bolts of a program and scaling it, as opposed to understanding what the need is on the community side and scaling to meet that need, right? The National Diabetes Prevention Program is an excellent program, but it's too long, too complicated. We got to figure out different mechanisms that meet the needs of what people want. So data that helps plan, strategize, set targets, knowing your denominator in terms of scaling up. The fourth thing is infrastructure and resources, right? And I'm not going to repeat what Joe said. I wrote this out before his talk, but I think you really embellished the idea of how important infrastructure. To me, that's your pot. Right? You can have all these ingredients, but you need a pot to make it happen. You need a person behind the scene to actually meet with people, talk with people, continue to push strategies and create that feedback loop to make things happen. And then the fire, to me, is leadership and vision. And leadership and vision is what really makes all of this cook together and make it work. And with leadership, it's not just about a particular leader. And I heard this a couple of times today. Having champions, the risk of that is that when a champion leaves or they die, that's it, the movement is over. You need leaders, right? And leaders come from all different sectors, from politicians to people from the community. And leaders need to be, you need to allow leaders to be not rigid. You need flexibility, right? The best leaders that I can think of, and I'll use the actor analogy, Marlon Brando and Will Smith, Cantinflas from Mexico. These actors can never memorize a script, but they were one of the best actors that we knew because they were given the flexibility of being who they are. Oftentimes, I'm not a big fan of it, but the movie that just came out, the Hunger Games movie, they tried to do a little video with her and put her outside of, in a stage and give her words. She failed, but when they put her out in the battlefield, she gave a speech right from her heart because she was in her environment. We can't take leaders out and give them a script and then expect them to lead and then expect something for them to take something to scale that they don't believe in. They have to come from within, and the passion has to be from within, and you can't make it rigid. And those are the themes, I don't know from what speech I heard it from today, but it's one of my takeaways today. So that's it. That's my turkey chili for the day. Now, I'm going to stop for a second, and I want to hear back from the audience in terms of the things that you might have heard today that resonated, that might be new, or something that really helped confirm an assumption or belief that you brought to the table. Any starters?
Hi, Mary Pittman, and during the exercise that we did with the Arena Theater folks, at the end where you had to go around and say a word, I felt like I was the skunk at the party because everybody was using hopeful, exciting words like that, and I said frustrated. And my reason that I said the word frustrated was not for the exercise, but for the fact that it seemed like what we were doing was continuing to define the problem. And I can say at the end of the day, I would change my word to hopeful, inspired, and much less, in conflict, because I feel like we moved from coming up with words that defined problem to creating chili, coming up with a recipe, looking at the bias for action, and some really concrete steps. So when I think about, what might we begin to define, I feel like we've gone over a lot of the building blocks and a lot of the tools, and we're probably at that stage.
Thank you, Mary. Jim?
I thought it was a good day, too. Really learned a lot and made me think a lot. It's interesting, a few minutes ago, I heard George say, when does this begin? And I think, interestingly, one of the challenges is that it already has begun. There are so many communities out there working on this in one form or another. And I know, we had an RFP where we sort of tried to get some communities to come on board, and we really restricted it to the communities we thought were ready. But my phone was ringing off the hook of people who wanted to get involved even though they weren't ready. So I think there are different stages of people activated. So part of the challenge for us is to say, how do you take it from where it is now, sort of a beginning movement, to the next scale, I think. And I think that should be something we recognize as we shape our future work.
A couple of reflections as I sat through the day and I listened. One of the things about scaling up population.
Oh, can you introduce yourself again? It's
Rashad
Rashid.
Massoud.
Thank you.
Can you hear me now? Yeah. Okay. Rashad Massoud, the USAID Applying Science to Strengthen and Improve Systems project. A couple of thoughts as I heard the discussions during the day. The first one is, in scaling up population health, we're looking at 3 levels, and the 3 levels are at the individual adoption level, that is getting people to act in certain ways. Another one is at the care delivery level, whether it's facility or community, it doesn't matter, but there's a delivery component, and then there's the policy level. And it's not one or the other, where we really need to be looking at all 3 of them, and they all interact with each other. The other thing about them is we talked about complex versus complicated, and to me, I think some of the things that were mentioned were really relevant about the complex versus complicated. Getting to the moon is very complicated, but we can actually predict it and we can do it, whereas getting somebody to stop smoking is much more complex, and figuring out which of the things that we're trying to do require what type of intervention, and they're very different in nature. I think these are important points. The second thing that occurred to me at the end when we were talking about how do we get started and what are the aims, I think Joe was starting to get into that level of, like, in order to make improvements, what are the improvements? The analogy, I'm not going to try and do it for population health. I haven't sort of looked at what you've done in the past, but let me take an analogy again from sort of a different world, something I deal with all the time. Maternal mortality reduction, which Joe showed as the MDG targets. So with maternal mortality, when you say maternal mortality, it's a huge thing. And for a country, trying to deal with maternal mortality can be overwhelming. But there are a few things that we know about maternal mortality. We know, first of all, the causes, the primary causes. We know that it's postpartum hemorrhage. We know it's eclampsia, preeclampsia. We know it's sepsis. So now we can work on each of these individually, and we have interventions that work. So it's possible to approach it as saying, of course, this isn't everything in maternal mortality, but at least we know that, and we can start working, and that can get us to a very good result on its own. It doesn't mean it's the end of the way, but it's a very big way to get there. The other thing we know about maternal mortality is what's called the 3 delays. That's delay in even recognizing the danger and the need for care. The second is the delay in getting to the facility that can provide the care, and then the delay in what happens within the facility. So again, as we recognize these, as we start to understand them, we're sort of peeling the onion, as if it were, and we're trying to drill down. We can set aims, and we can have very specific actions. I bet if you sat down and looked at some of the issues that you're dealing with, you can come up with a menu of, okay, these are the primary things that we need to tackle, and here's how we can get started on them. And you can also what we found is that it's very difficult to take on all the things at once, but you can phase them, starting with the easiest and building up in terms of complexity. And that's one way to tackle a very large, complex system like the one that we're dealing with. Thank you.
On this side.
I'm Sally Herndon from North Carolina Division of Public Health, Tobacco Prevention and Control. And the one thing that I wanted to add to what we've talked about today is just some appreciations for getting to be here. And for my staff and my coalition at home. A lot of the things we've accomplished in North Carolina have been done in good times and in bad. And it's about financial resources as well as people resources. Some of the people resources, when Michelle asked me the question about how we got the youth movement going, I neglected to say that we had kind of unrestricted resources from the Robert Wood Johnson Foundation and the American Legacy Foundation to help train youth, empowered youth to get moving. We don't have those resources anymore, and we're kind of on a shoestring now. So that was a fabulous tool to be able to help bring young people up, to give them critical thinking skills. And as Jeanette said, it's for more than tobacco control. It's to be an active member of the democratic small d process to help bring solutions to complex problems. So I just want to say thank you to all of those funders who have contributed to that, and then to those on my team at home who also continue to make that happen in lean times too. Thanks.
Thanks, Sally. On this side, Neil.
Neil Kaufman, UCLA and DPS Health. I think I want to reflect on maybe a business way of thinking about what we're doing here. Each of us, I think, come from different perspectives, but we might all agree that we think of ourselves as the R&D wing of agents of sustainability and scalability. Those agents of sustainability and scalability include the individuals, the communities, the foundations, governments, and others. And just as in a company, the R&D wing would not build something that the company was not going to sustain. We should do the same. And what that means is that at the research level, as we're creating these summative-based evaluations of evidence-based programs that are effective, we should be thinking about how it's going to go to scale. The typical NIH grant, the one I'm most familiar with, is the Diabetes Prevention Program, as you mentioned, highly effective but unaffordable and unscalable because of way too much personnel costs and other issues. If the original researchers had thought, I'm going to go to 50 million people, I'm not going to go to 3,000, as they did, they might have done things very differently. So at the beginning, how do you do that? The second element, if you're the R&D wing, is you're going to be testing every way along the path the agents of sustainability and scalability's opinions as to what they need to know, what level of evidence, what level of detail, what level of whatever the value they may have as you do your projects. So in some cases, what we have found is people care about outcomes, not surprisingly. They all say they care about healthcare improvement and cost savings, but most people don't buy for that reason. They may buy for many other reasons: customer loyalty, member retention, PR, being thought of as a leader in the field because it's important to me, and all those sorts of things. So the question becomes, how do we maintain those relationships as well as those understandings of what the agents of sustainability and scalability really want along each stage of the scalability continuum? And I really did enjoy the meeting. Thank you very much.
Thanks, Neil. So planning for scale, right? So from the beginning, planning from scale. We heard that from a couple of speakers today. Paul?
Paul Jelinek, Isaacs Jelinek. You know, I heard a lot of very useful insights today about what it takes to get to scale. It seems to me, based on my experience, not just with foundations, but with lots of nonprofits, health departments, governments, that one of the biggest challenges is people don't recognize the importance of getting to scale in the first place. We're talking about population health, and yet you continue to see people operating on a much smaller, and thinking on a much smaller scale. So until people recognize the need to operate at a different scale, to scale up, you know, we're not going to make the kind of headway we need to make. So I think there is another part to the challenge beyond sort of, if you want to get to scale, here's how you do it, which is what we talked about today. There's a sort of preliminary issue of how do you help people understand the importance of getting to scale in the first place?
and policymakers, right? From policymakers to researchers, we got to drive that message home. We can't wait for 5-year RCTs from federal governments to be completed or take something to scale. Great point. George?
Yeah, just a couple of comments. I share David's thoughts about our drivers, but I think that I take comfort from what we've learned today in terms of the fact that it's kind of okay to change our strategy as we go along. We don't need to fix it in stone. But having said that, I have a couple of thoughts about those drivers since I offered them up this morning before we had any discussion of them. On the metrics, I see that if we're thinking about metrics in terms of creating improvement in health, we need to think about metrics in a multifaceted way in terms of not only how to measure and monitor health, what kind of infrastructure is needed to engage communities at a granular level, but what kinds of daily metrics we need, all of the last speaker, to monitor efforts, and what kind of robust system of using measurement do we need to develop in terms of types and purposes for which players, which government, which private, how they're focused for different kinds of efforts that build up to this effort of improving population health. So it becomes a more robust and complex kind of topic from my perspective.
And put in a plug for our June 30th workshop on population health metrics, which will be informed by this discussion today.
On resources, I thought about it in terms of, as I teed up, in terms of what we lack in resources for social determinants beyond healthcare, and then what we're wasting in terms of resources, in terms of excessive resources for healthcare. But I hadn't thought about it so clearly in terms of resources opposed to change, as the tobacco illustrated. I hadn't thought about it in terms of overall strategy with respect to how economic power, balancing economic power either wins or loses. I think we would be well-minded as a group to think that through a bit. I don't know what conclusion we'll draw, but that has opened my eyes. That's new for me. Relationships, I guess it reinforced the need for a lot of collections. I certainly have been delighted to see the experts on this panel and think about them as assets and resources, the experts in this workshop, and think about them as assets as resources as we engage in this effort to improve population health. So add them to that relationship sort of circle. Research, questions were raised to me about the body of research and how siloed or fragmented it may be, and how we need to think about bringing it together if we want to get our arms around improvement and scale and scope. Policy, I was inspired by the North Carolina end around for some of the typical blocks that might be at state level policy that they've achieved in spite of some difficulties there. And then communication. And I've been thinking about this for some time in terms of my main sort of focus in terms of healthcare delivery strategies and contemplating the power of consumerism in healthcare delivery, particularly as encouraged by the ACA and some of the work I do for governance, which is a very powerful trend that gets a lot of attention. We need to think about that in connection with our topic of health and engaging the social determinants. The democratization of communication and mechanisms, I think, holds profound influence for us. This discussion today has really driven home our need to pay much more attention to that. We had that in the communication workshop. It was reinforced in this discussion.
Thank you, George. Jeanette?
Hi, Jeanette Noltenius. There is also something that just is sticking with me is when we think that we want to scale up, and if we don't, and if we leave people excited, if we go to the community and work with the community and then it dies, there is a cost. It's what I called a disrespect cause, and it also, it's a discouragement to the community. and it becomes a barrier for future scale-up possibilities. So, you know, when you go into a community, it's like, don't open a Pandora's box that you cannot close in many ways. So you need to be thoughtful that there is a cost of not scaling up when there is the possibility to do so.
Lourdes Rodriguez with the New York State Health Foundation. And if I make no sense, it's because my brain at this time of the day goes into Spanish mode. And I am going to try to make sense of my comments based on notes from the day. There was a moment in one of the conversations today where this notion of people taking advantage because it was in the context of talking about that edge between where healthcare finished and another system picked up, the system of housing, and how all of a sudden giving free housing to people would lead to people taking advantage. I want to pick up on that because the language is very othering, which means that the moment that we talk about who's deserving versus undeserving, who's entitled versus who's a beneficiary or who's taking advantage of the system, we are forgetting that when we're talking at the level of scale of the population level, there's the people who may be taking advantage of what we're trying to set up are going to be so minuscule in reference to the number of people that are going to benefit from what we're trying to do, that the fear of being taken advantage of should not stop us from action. And that thought got compounded when we were talking about the tobacco industry's very, very sneaky strategy of changing the weight of the product so that they could take in a loophole that allowed them to put flavoring in cigarettes. If that is not taking advantage of a loophole, I don't know what is. So we're setting these evil double standards of industries are allowed to take advantage of some implementing marketing strategies in some communities, or the way that they target specific populations. And so if what's good for the goose is good for the gander. So if we're going to talk about not take advantage, then let's talk about industry taking advantage, which then made me think about how a lot of what we're talking about is how all the problems that we're trying to solve are problems that were generated by industries, right? So these are industrial epidemics that were generated because of the scaling up of, for example, processed food, right? So if you think about how added sugars that are making people, sugar, fat, and salt, are making people addicted to some foods, that's fuel the diabetes and the obesity epidemic. And so if we're going to be talking about scaling up efforts, then maybe some of the efforts that we want to scale up is in taking some of the industries that have fueled some of the epidemics that we're trying to address, taking them to be responsible for the mess that we've made. My mom taught me that if you mess it up, you're responsible for cleaning it up. So I would like to call to task some of the industries that have taken us to this place.
And honestly, I want to take that note and maybe just plug a seed for more conversation around, George, your point of identifying the enemy, the villain in this trying to scale up population health improvement. I guess I want to hear from people who in this room you think those villains are. I just want not to name them or point fingers, but to better understand what's at hand in terms of this struggle. And I know this is going to be recorded, but we can be as ambiguous as we'd like. So I'm going to come to Pamela and come back to this microphone. You. No, what your comment was, I was plugging that thought for future conversation.
Thank you. You asked us what, Pamela Rooster Robert, you asked us what we, what we learned today and what confirmed. And so, you know, it's a combination of both because, you know, I think starting off with operational engineering and operational management and what that can tell us about spread and scale should be intuitive, but you know, it's not always intuitive that you would think that way. It struck me how much IHI has been involved in a lot of things that I didn't know that IHI did. I mean, when you said that the 100,000 Lives campaign was informed by IHI and your work there and your work, I was really struck by that. But then it should make sense because it's about change management. You know, it's really about change, and there's sort of like experts on change management, and particularly social change. And then there was some conversation about simple problems, complicated problems, and complex problems. And there's a great article in the Stanford Social Innovation Review from this summer by Kania and Porter, I'm forgetting the other author, on a new method for philanthropy, that if philanthropy is trying to approach a complex problem, they need to use an emergent strategy, not the older sort of strategic method that had, you know, rigid logic models and summative evaluations and, you know, and but that for a complex problem you need something that's much more emergent. And so I think a lot of what and so that trouble makes, we also heard about a great number of initiatives that really accomplished their goals in a big way that we would say improved population health. But as far as we've been talking about beginning, I mean, we do still have this rather generic term, and I don't think we want to go toward like a winnable battles kind of thing where we would choose 6 or 7 or 8 concrete things that we wanted to change, because we're so aware of the interdependence of all of these things. But so it sort of made me wonder, again, sort of the even concept of population health improvement is complex, all those interdependent factors. What's the best way to make the change that we're looking for to improve?
Yeah. Okay. Yeah. So on this side of the room, and yes, please make 1 or 2 minutes for your comments.
Jean McGuire from Northeastern University, and I wanted to comment on the arc of the day and how it was useful and maybe challenging and reflects maybe some of the extending the complexity that George was bringing to metrics. So Anita's talk where she was using the word resilience as a replacement, which I'm mixed about because of some of the complexity of the word. Nonetheless, very powerful discussion, and she gave us these facets that also could be metrics if you were thinking from the consumer, patient, the people that are going to democratize the thing point of view in terms of what they would care about. Quick coordinated response, enfranchisement, happiness, you know, deep specialist knowledge, affordability. Those are not the metrics we're struggling with that we're going to try to use for the entities so that they have an outcome that we can get savings from and then reapply it to another place. So it strikes me that the process of moving forward and thinking about our deep focus on industry and resources to pull from that to apply upstream or to other sectors, if it doesn't take into account the actual goals and objectives that would matter to people that are going to democratize the movement and spread it, then we're going to have a misalignment. So I appreciated the arc of the day, and now I don't know what to do with that.
Actually, I'm going to come to Debbie, and I have George have the last word for the day.
So in terms of what was new, or maybe reinforcing, the first speaker's point, Anita's point about diminishing marginal costs, and how to build an affordable platform for scale. I thought that was something I'll remember and really think deeply about. The second one is that we're really not spreading programs. We're really spreading outcomes. And really, Rashad made me think more about that when he made the point that we're not just replicating programs. Right. It's going to evolve. These programs will evolve based on the community, to your point, Jacqueline. And ultimately, what we really want to spread is the outcomes. In terms of what this confirmed to me was that this work is hard, and that you have to be in it for the long haul. And and that, it confirmed the whole learn by doing. Just get started, let's do something, let's learn by doing. And I think the 3 questions I had was, one, how do we bring the payers to the table? Because I think that will be a key accelerator. I hear what Joe was saying, that I think maybe we're getting there with the 20%, but if we want to accelerate action, I think we need to get the payers at the table. And then I guess my other question is, how do we build a sense of, a shared sense of urgency? Because when I heard Linda speaking and some of the other panelists, it was clear there was urgency. And that was really motivating the work. And I think part of it might be if something has an explicit time-bound aim. But again, people have to share that, and agree to that time-bound aim. And then it made me wonder, a question for Joe on, in his chart of typical versus exceptional, urgency wasn't there. And I wonder if you thought about that, but you don't have to answer me now, but it's just a question for you to think about, is because it does seem like you have a certain urgency in the work that you've done. So isn't that one of these factors to consider?
And also people personally connecting to the emotional side of things. The urgency comes, or the sense of emergency comes from Ed Gibbons.
George, you have the floor.
Just, George Isham, Health Partners and co-chair, just to be clear on my enemy's comment, because I think this is important.
Yeah.
We need a strategy to improve population health in all of the states, not some of them. We need all of industry to support the change, not some of it. We need it to be bipartisan, not liberal versus conservative. We need the smart people and the not so smart people on board. We need all of the cultures, all of the races. And so we need to think carefully about what we've learned from movements and this discussion, the tobacco movement, about the side effect of creating a strong, entrenched, well-financed enemy. And so what I'm asking us to think through, without coming to a conclusion, is think about carefully about the next iteration of large social policy and strategy, and to think about what lessons we can learn from what's happened before that ought to inform the next round being smarter. I am not suggesting a solution. So I think, Jacqueline, it would be a big mistake for us to begin to identify a list of potential enemies.
Good. Well, I wasn't suggesting we should. I wanted to see what would spark, what ideas would spark. So thank you, George.
So thank you for all that. Actually, I wasn't going to say another substantive word, but George just got me going. I'm going to take a risk at the end of the day. So I actually, because you've prompted me to think about enemies. I actually think that the largest enemy is the American public that still believes that medical care equals health, and all that underpins that belief. It's a different kind of enemy, but it's not necessarily food companies. So on that, I'm going to thank again all of our presenters. All of you have been here that have stimulated these interesting conversations. Thank you very much for a great day. Our next session will be in February. It will be on the interrelationships between primary care and public health. In April, we're going to have a session on using simulation forecasting models, particularly for moving money around in the population health system. And we will go on to a number of other items during the year. So thank you very much. For Roundtable members, I believe the bus should be outside shortly to take us back to our hotel. So thanks again, IOM staff and everyone for all their work.